Welcome to our first webinar or presentation. I'm hoping that eventually we'll be able to have some people here in our hall, our little seminar room in the future. So I'm going to take you today through early detection and management of chronic kidney disease and looking at how we delay the progression. I am a staff specialist at St. George Hospital. I also am part of the primary education committee for PEAK, and I'll tell you a little bit about that later. So our learning aims, which I'll give broadly, and I'm going to, throughout the talk, have quite a few slides that are available in a handbook, and I may go through those a little bit quicker. They can see the screen. So I'm going to provide you the tools for early detection of chronic kidney disease. I'm going to get you to understand the principles of both the progression factors and the risk factors for CKD and AKI, acute kidney injury, as well as the incidence. We're going to look at some of the management targets, which we aim for to reduce progression of both kidney and cardiovascular disease. We'll look at some of medication changes and that happen, and also we'll look at how we assess CKD and also the kidney health check, which is going to be very important, as well as timing of referral. So if you look at those learning factors, I'm going to go quite quickly through some of them. As I say, many of them are available. This talk is developed by PEAK, of which I'm a committee member. It's volunteer nephrologists, we've got renal nurses, there's GPs and other health professionals, as well as patients who participate in drawing up these talks. It's obviously been modified for Southeast Sydney. So I'd really encourage you, as I said, to download the 4th edition of the handbook, as well as, if you haven't got the CKD Go app, to go and get it. They are basically the same thing. They're very easy. Why should you use this handbook? It's very easy. It's interactive. It gives you a quick reference guide. It's color-coded, and I'll show you some of that through the talk when we go through a case study. Look at it gives you all the medical advice and treatment targets. It explains what's appropriate in terms of CKD complications, nephrology referral, and then we'll give you some useful links, many of which are going to be here. So things that are in the book, I may go through quite quickly. I won't go through all the details so that we can get to the end, because I think questions around referral and how you get patients into hospital is important. And if along the way there are any questions, Kylie is here with me. Kylie Turner is the CKD CNC. Who works with me with the community structures and integrated care, is going to just let me know. So just to tell you, there's a few things that are new in this edition. If you've got the old edition, why do you want to get it? We discuss hypertension targets, which I'm going to discuss today, the quick reference guide, there's certain algorithms, sick day plans. There's a lot of expanded information about how you would approach managing CKD in your practice, how you get patients, self-management, what sort of integrated resources are available, your goals, and common issues around CKD. But let's get to what we really are speaking about today. What is CKD? Now, this is very important because very often we get referrals of patients who don't necessarily meet the criteria. You'll have somebody who has not necessarily had a GFR of less than 60 mils for 3 months when a referral is initiated. CKD is defined as having a GFR which is consistently low over a period of 3 months. Now, you can either have it where you have no evidence of kidney damage, so you can have people who have a glomerular disease with very little damage, but there's damage to the nephrons, and you'll get a decline in GFR, or you can get, just with age, a decline, but you either have to have that for 3 months, or you have to have evidence of kidney damage with or without a GFR. So you can have a normal GFR, But if you have any albuminuria, proteinuria, if you've got hematuria and you've excluded a urological or surgical cause, you may just have structural abnormality. So you may do an ultrasound, you see polycystic kidneys or cysts, but the GFR is normal. If that's there for more than 3 months, that is considered to be kidney disease. And sometimes you may have normal GFR, you do a biopsy and there's a minimal change in nephropathy, and we know you've got glomerular disease. So any of those things are defined as CKD. So when I talk about CKD in the talk, that's what I'm talking about. So how many people in Australia do you think have chronic kidney disease? 1 in 5, 1 in 20, 1 in 100. Usually when people are here in the audience, they can tell me. Wayne's here, so he can have a quick guess. Yes, Wayne, you're correct. 1 in 10. That's right. So 1 in 10 people have it. What does that mean? It means, if you look in the context of Australia, that is 1.7 million Australians will have chronic kidney disease by this definition. In fact, these sort of slides are often us specialists sort of trying to highlight how important our organ is. So I don't want to make you feel like my organ's more important than the other. In fact, you'll see in this talk, I try and tell you how important kidney disease is in relation to other diseases. But CKD, if you actually count the numbers, is more common than diabetes, and that means 1 in 3 Australians. But this slide is really important because CKD, if you have it, so if your GFR, it is a stronger risk factor for coronary events than having just diabetes on its own. And I'll show you why. CKD also has a significant impact. You know, if you go on dialysis, if you get advanced disease, it can really impact on family and psychosocial well-being. When you have CKD, you already have a 2 to 3-fold greater risk of cardiac death. So a lot of people are going to die every day with kidney disease, and I'll go through some of these links. So when you think of CKD in your head, you should have another light should come on immediately that says cardiovascular disease. They're linked. What else is important is that it's treatable. We can reduce the deterioration in kidney function by up to 50% if we pick it up early. If we manage CKD early, I often say to the patients, if you're managing CKD, I'm managing cardiovascular disease at the same time, so they're risk reduction. The problem is that fewer than 10% of our patients in the CKD group, all the way from stage 2, which is not really advanced disease, down to 4 before you get onto dialysis, and even some 5, as I'll show you, aren't aware that they've got kidneys. So 90% of people don't know. Excuse me. The other thing is that about 20% of people are referred late. So, and by late referral means they get referred to us and they start dialysis within 3 months. That number is very important to us nephrologists. If you refer patients late, they do worse. The survival is down. What causes CKD? Well, just generally, it's diabetes and hypertension predominantly. In Indigenous Australians, it is more diabetes with glomerular disease and polycystic kidney disease being also important. There's a number of other causes. So this is trying to give you a sort of understanding of renal failure or kidney disease. 10 years ago, we wanted to call it kidney disease because we felt didn't understand what renal failure is. For some reason, renal failure is coming back into vogue as a term. But it doesn't matter what you call it. I think you've got to recognize kidney disease is a continuum. It starts with proteinuria or albuminuria, and along the way, you will eventually get decline. Once your GFR gets to around, and the reason why we categorize kidney disease into these stages is because along the way, you will develop morbidity, complications, anemia. Usually only when the GFR gets below 45, which is or 30 at this sort of line here. And when you get to that 30, that's where we have to make those decisions. Is this person going to start dialysis? Are they going to go onto a renal supportive care pathway, a non-dialysis pathway? What about education? And when GFR goes below 10, then we consider starting dialysis. That's advanced renal failure. I want to highlight here, I've just stuck it in here and I haven't shown you more detail, but we aim for home hemodialysis. Very often we have GPs, and Kylie will tell you, we have GPs telling our patients, no, you're going to go into hemodialysis. We don't. The survival on home hemodialysis is better than on in-center hemodialysis. Either home peritoneal dialysis or home hemodialysis is what we aim. If we can get a patient onto those two modalities, the survival will be better. So early referral, good education with Kylie early on in her clinic, in a pre-dialysis clinic, will help us get that target. So we really want you to be telling patients that you will have these options, but we want to have you at home. This is the conceptual model which was developed by Guy Levy in Boston, and we sort of follow it, but pretty much start with normal kidney function. You've got increased risks, so hypertension, diabetes, age, and I'll go through those with a case study. You get damage, and then we try and reduce the progression because the eGFR will decline, and we eventually get to kidney failure and death. At all of these points, we try and intervene to improve outcome. Now, this is not traditionally in this talk, but I always add it in because when people come to my clinic, I always tell patients, I often get patients referred who are elderly, and after the age of 45, you decline your kidney function by 1% a year. So if you work out normal is 90% or 90 mils per minute, and that's the reason why we talk about GFR, because it's like talking about percent, and people understand percent better than mils per minute. But you can see most people, and this slide doesn't demonstrate it, but 80% of 80-year-olds will have an eGFR below 60 or a lot. That does not mean you've got CKD. If you've got associated risk factors, that would make it important. But what happens when you've got disease is that this decline in GFR is really increased rapidly. And I'm going to show you a slide how hypertension really, if you don't control it, how you can steepen this curve. And that means if you're 25 and you're declining by 5 mils per minute, you're going to be on dialysis by the time you're 45. So what I always tell patients, I am aiming to change this curve. I want you to have kidney disease, but still die without needing dialysis. If I can change the slope, I can change your future. There's also a lot of things that you guys can do in your practice. I know Wayne participated as an ambassador program for CKD, and we still run those programs if you're interested through Kidney Health Australia, where you set up your practice to where you've got yourself and your practice nurse looking at item numbers and behavioral changes early on. Obviously, as the GP, you're going to sustain that ongoing relationship. You're going to coordinate care, ensuring good outcomes, and the individual, you understand the individual goals of your patients. You are the advocate for that person. And so the responsibilities we acknowledge is in the primary care. The support, the management plans, the screening, all the common issues of CKD, all the prevention and psychosocial services will happen with you. The other thing is that you can actually set up if you've got a primary healthcare nurse, to identify people in your clinic who've got CKD, tell you, discuss self-management. Or this is all available also for people online from Kidney Health Australia, how you can speak to patients, educate them, and offer continuity of care. Now, I always love showing this slide because, and you always see these slides, there's always a triangle or a, but what you can see here, this nearly 2.5 million people, only 10% of people are aware that they have got renal disease. There's a lot of people at risk, and about 25,000 people are on dialysis or have had a transplant in Australia. And what I always ask registrars when I talk about CKD is, how come there's 1.2 million people here, but there are only 25,000 who make it onto dialysis? And the reason is that most people die. So you're lucky if you get onto dialysis, you actually have a survival advantage. to make it there. But this is really interesting. In this survey in Australia, what they found is that although we've got all these people here in the dark gray on dialysis or on transplant, there's thought to be at least another equal amount who are not on dialysis, who are the elderly people that you're seeing in the community that are not going to get dialysis. And they're usually a little bit older, and you know you've got these patients in your service who you elect not to maybe go for various reasons. But it's just to show you that we're seeing only a small proportion of those patients. You're seeing a lot of others, that light gray area, probably in your practices. Now, this is one of the reasons why albuminuria is so important. And I'm going to go through it a few times today, because it's one of the most common problems that nephrologists don't do, is do an albumin creatinine ratio. And it's a common issue where I don't get referrals with albumin creatinine ratio. Why is it so important? The reason it's so important is GFR will decrease. And as your GFR decreases, this slide is looking at your hazard ratio of getting cardiovascular mortality according to GFR. And you can see as it declines, your cardiovascular risk goes up. So that's why I told you that CKD, you've got 2 or 3 times increased risk of cardiovascular disease. The other problem is even at normal GFR, if you've got normal albuminuria in the blue, microalbuminuria or macro, so the more proteinuria you have, that will increase your cardiovascular mortality. So looking at proteinuria and albuminuria is really important for you to decide how aggressive you're going to be. This slide is just showing you the albuminuria against developing end-stage kidney disease, and you can see again, if you're in the macroalbuminuria range, that's a urine ACR more than 25 in men and 35 in women. So get 30 into your head. Roughly, if you're more than 30, look what it does in terms of your risk. Your risk 64 times increase. So it's really important to recognize that. Now, why do we use GFR? And this slide is to demonstrate. So you can see here, this is the normal creatinine as your renal function declines, and then all of a sudden it just steeps up. So what can happen in this, I hope it's projecting for you, but at this stage here, at 30, you're needing dialysis here. And look at that steep curve there. So you actually, if you're watching the creatinine, you're going to miss all the early stages where you can really make an impact. Because if you're watching creatinine, it's going to be too late. By the time the creatinine goes up, the person has already got advanced renal failure, and all the complications, all the risks are already there. You've missed the boat. So GFR is really important component. What is the significance of it? So if you detect early, CKD helps us to stage and assists with goals, so we can reduce morbidity, mortality, reduce cardiovascular risk. We can slow progression of renal disease and prevent complications. If we can treat early, we can potentially reduce the rate of progression by between 20 and 50%. So that's pretty significant. Now, I just want to warn you, I'm not going to go through all of these, but sometimes I have had referrals of patients with abnormal GFR, but the patient looks well. Usually these patients are like big, bulky guys. So your GFR can be affected by various things, liver disease, pregnancy. This is in the handbook, so I'm not going to go through it in detail, but GFR can be impacted by various muscle mass, etc. The other important thing is that GFR, and I'm going to take you to the bottom of the slide first, is that GFR is calculated by the CKD epi. Now, a lot of drug dosing uses creatinine clearance to make and the first person to design this were 2 pharmacists. The pharmacists have got a little bit upset because the nephrologists have stolen creatinine clearance away, but eGFR is the same as using creatinine clearance in terms of your drug dosing. The difference is that you should take into account their body size, and you obviously must look. And there are different therapeutic indices for different drugs, so you may have to watch it depending on the GFR. But the bottom line is just the GFR is as good as using creatinine clearance, so the Cockcroft and Gold formula. In fact, the CKD the Cockcroft and Gold formula was just on a few patients. It was about 30 or 40 patients only. The CKD epi formula, which you get on your lab form, is an international study which comprises 700,000 patients. So it is it includes people with normal renal function and abnormal renal function. A much better test than the creatinine clearance. So you can use that. Just some tips around urine ACR, the albumin creatinine ratio. You should do it in the first void specimen. If you can't, then you can do it randomly as a spot during the day. This probably changed nephrology in primary care more than anything else in the last 20 years. When Raganenti showed the correlation between a 24-hour collection and the ACR, it really revolutionized our ability to pick up risk, and it revolutionized our ability to now be more aggressive and recognize how it will impact on progression. So this slide is pretty much it. I told you that albuminuria tells you how people are going to progress. It's predictive of outcome. I've shown you the slides. Microalbuminuria is predictive of progression versus no albuminuria. You can intervene to delay, and also if you can reverse ACR by small amounts, you can improve and it has renoprotective effects. So just remember, there are some things with ACR. Again, I often have referrals coming on a single ACR. You should do repeated tests. You should, if you're going to use it, the dipsticks is not accurate any longer. You can use certain point of care testing, but it has to be a microalbuminuria stick, which we have in our clinic. You should send at least 2 out of 3 ACR tests should be positive before you label them. So I told you CKD, if the GFR pops below 60, don't just label them CKD, rather look to see if what was their cause, if on repeat measurements it's there, they've got CKD. The same with albumin creatinine ratio. Don't just do one, do multiple tests along the way before you make the diagnosis. Again, this is in the book. It's just showing you that, look at the bottom, what's normal and how it correlates to a 24-hour urine collection in terms of milligrams per day, which is often how they look at diabetes. So about 300 is equivalent to 30, indicates macroalbuminuria, and on a 24-hour it's equivalent to 500. We don't really use protein creatinine ratio. We only use that in pregnancy, and we often use it only in the nephrology service, like when we're looking at very heavy proteinuric patients with glomerular disease. Otherwise, urine ACR really is what you should be doing. So I'm now going to cover a few things around those targets for managing kidney disease. So hypertension has changed a lot. There was the Accord study and the SPRINT study that really aimed to change our target. You're going to ask, why do we in Kidney Health Australia on the peak go for 130/80? And in our department, we usually target that. We feel that a single BP target is easier to reach, and we felt that the message should be simplified, and obviously you have to individualize. The problem with the SPRINT and Accord studies is they didn't have diabetics in there, and they didn't have people with a lot of kidney disease. And so if you target 120/80 in an elderly person with diabetes, you're going to have hypotension, hyperkalemia, and if they've got cardiorenal disease, you're going to get heart failure. So we targeting lower blood pressures because SPRINT has said we can, but if you get a young person who's got albuminuria, you've got to go for it. So let's look at a case study. In terms of time, I think we're going okay. We've got a 63-year-old woman who comes to you, is an accountant, history of mild asthma. Rita is a new patient in your practice. She is overweight. She has mild intermittent asthma, chronic low back pain, mild hypertension. There's a history of cardiac disease and kidney problems. Mother was diabetic, father angina, so cardiovascular disease and hypertension. Also a smoker, 20 to 25 cigarettes a day, only 1 to 2 units of alcohol, and uses salbutamol. So does Rita have an increased risk of CKD? Luckily, Wayne's here, and he says correctly. Wayne, you're on the button today. Exactly. You've got to look at the risk factors. So 1 in 3 Australians, I've told you, have increased risk factors for CKD due to their risk. And if you have a look at Rita, she has hypertension. There's a family history potentially of kidney failure, and she's a smoker. And there is a family. So she has 4 risk factors, okay, for CKD. So a risk factor like diabetes, just to give you an understanding, if you've got diabetes, patients who have diabetes have a 30% increased risk of developing CKD. 1% of adult Australians develop diabetes every year. So that's why you saw in the very beginning why it's such a common component of CKD. The other important thing that I often have to explain to patients is that blood pressure, the reason why you get damage, if you look at those nephrons, and I'll show you a picture, they really are tiny little blood vessels. If you damage those little blood vessels, eventually you lose filters. I showed you in that slide, you lose filters anyway from the age of 45. So if you worsen that, you're going to get established damage and scarring in the kidney, in the filters and in the tubes, and then that will lead to hypertension. So it is a little bit, the one actually interacts with the other. So it's like that old saying, which heart failure begets heart failure, CKD begets CKD. Why is obesity a risk factor for Rita? Well, you can see if your BMI is more than 30, you get almost a twofold increased risk, and if your BMI is over 40, almost a threefold risk of CKD. This is probably again related to the fact that these patients get hyperfiltration. They're big. The kidneys are really only designed to look after a smaller patient. They get hyperfiltration, so you get scarring. Of course, these patients also get diabetes and hypertension. So the combination of the two things make them at increased risk. What about smoking? Smoking is one of the biggest risk factors. And that's why whenever I see a patient in the clinic, you'll often get a letter back to you saying, please, can you look at stopping smoking? You can see twofold risk if you have a 50-pack-year history and a 105% increased risk in terms of percent, and 40% if you're in the 25 to 49 range. This is still a blight on us here in Australia, that our Indigenous colleagues have a 4 to 6-fold increased risk of kidney disease at all levels. So that's that is something to remember. One of the things that's added also into the newer, if you haven't got a newer handbook, acute kidney injury is now on this list. So whenever somebody comes to the hospital, even with one episode of acute kidney injury, they may not necessarily repair. They may get an event where they sort of follow a trajectory down here where the GFR declines. And if you have multiple events, you have the potential to more severity, more acute kidney injury. And there's studies showing if you develop acute kidney injury, you've got a 4 times increased risk of end-stage kidney disease. That was published by John Myberg in the NEJM from work done in Australia. So we used to think the kidney will just heal and repair, but very often with inflammation and tubular damage, and we land up with a scarred kidney with multiple risks. So just acute kidney injury and CKD are actually interconnected, and they share the same risk factors and the same potential outcomes. Now, why is the kidney so vulnerable? Now, I love this slide. It was given to me by Mark de Breu, but your kidney is getting a quarter of your blood flow. these tubules are very high metabolic rate. In fact, the oxygen requirement in this gray zone in the kidney, I'll go back here, is more than is required in the brain. It needs 80% oxygen concentration. Your brain on average needs 70%. And that's to do all the jobs. So if you get a nephrotoxin like ACE, or you using ACE and non-steroidals together, you're going to just really induce ischemia. And once you develop ischemia, you're going to get acute tubular necrosis and kidney damage. So drugs are important factors that will damage the kidney. So what would you do next now that you see Rita has increased kidney disease? Wayne, unfortunately, is the person here. Luckily, he's hung around with me for a long time and we talk a lot. So you're correct, Wayne, that you would have to, if you've got to do the kidney health check. Just because she's got the risk factors doesn't mean she has CKD. You've got to look, and in somebody who's got hypertension or diabetes, they should do it every year. If you've got the other risk factors, you can do it every other year. But if you look at her risk factors, what are those targets that we look at? Serum creatinine and eGFR in the UVC, the blood pressure, and the urine albumin creatinine ratio. So this kidney health check, often when I write a letter back, if you've seen a letter from me, I will have said to you, please, I'm discharging this patient from the clinic. They've got renal failure. The GFR is 55, but just do the kidney health check every year. And that's what it comprises: the blood test, the urine test, and a BP check. So if we look at Rita, her creatinine is 118. It actually doesn't look so bad if you look at it against her normal, but her GFR is 55. So it's just to show you that creatinine does not increase. She already has stage 3 CKD, stage 3A CKD. She's got microalbuminuria and she's hypertension in your check. So again, Wayne, does she now have chronic kidney disease? You're correct, she does not. Not yet. Because I told you to diagnose CKD, you should repeat the urine ACR and the eGFR again. I get a lot of referrals and we send them back to you saying, look, check it again, do an ACR. It does not necessarily mean that you have CKD. Recheck it. If you can't find a reason, there's not a drug or a cause, there's lots of reasons why your albumin creatinine ratio may be down. So CKD, you need to do 2 or 3 repeat tests. eGFR may be unreliable. I've told you it's unreliable in pregnancy. It's unreliable if you've got a big muscle mass. I had a guy who looked completely normal. He just happened to be a plumber. He had these beautiful big muscles and his GFR was low and he was referred, and that it was just because of it was unreliable. So you should confirm it on multiple, and if there are any nephrotoxins. So what can affect urine ACR? If you go back to your school and in the Italian O'Connor, if you've ever used it, will tell you urine tract infections, congestive heart failure, any one of these things. Using non-steroidals can give you albumin creatinine ACR that's up. So you should stop it and repeat it again to make sure it's not one of those components. Rita comes back to you in a month's time or 2 months, because the GFR is not terrible. You do a urine ACR again, and now you can see it's persistent. Okay, her ACR is clearly, she's got this visit to albuminuria is a little bit worse. GFR is slightly down, and she's still hypertensive. So what's the next step? Correct, Wayne. Tackle those cardiovascular risks, or in fact, what you should do in your handbook, you can just mark her and you can see she goes into the orange group. If you've got the handbook, or if you've got the handbook, or if you've got the app, you can do it. So I'm just going to stop a second. There's a question here. How long do non-steroidals need to be stopped before rechecking? Probably at least 10 days, 10 days to 2 weeks. Non-steroidals give you severe vasoconstriction in the glomerular, the little microvessels, and causes ischemia, and you should stop it for at least 10 days. Unfortunately, I've had some patients who've used it long-term and they've already got established damage from non-steroidals. So anyway, just go into your book, it tells you how often you should see the patients, and it's got quite a guide. Now, look, there are some strategies that we at St. George are slightly different. That's probably because I've got a particular interest, but we'll discuss those later. As Rita's, how do you reduce the risk of cardiovascular disease? Well, of course, you've got to tackle those components that you can do it. So you could do a cardiovascular risk check. You could check on the CVD risk, because if you've got CKD, I told you already, your cardiac death risk increases by 2 to 3-fold. In fact, often when patients come to me, only 4 out of 20 people will actually land up on dialysis when their eGFR is advanced. Most will die because they've got a 20 times increased risk of cardiovascular disease. So you really got to tackle those components. So you've got to remember also the cardiovascular risks checker is redundant if you have persistent proteinuria or your eGFR is less than 45. If you're at that level, you are already at the highest risk. So you don't even have to do the risk calculator. These are the patients you have to target aggressively cardiovascular risk reduction. You don't have to do the risk calculator. That's not going to tell you anything. The risk calculator also doesn't help if you're diabetic with microalbuminuria, if you're more than 60 years, if you've got established cardiovascular disease. So the calculator certainly is not just a be-all and the end-all. So with Rita, she's got 3A, she's got microalbuminuria. We've got to target that blood pressure and get it down. We ideally aim to use ACE inhibitors or angiotensin receptor blockers, but if you have a 25% reduction from the baseline, it usually does stabilize, but we suggest that you stop ACE inhibitors. But if it is less than 25%, you can continue. So you always will get a slight reduction, or not always, but mostly you get a slight reduction. And the reason you get that is because the RAS blockade affects the efferent arteriole leaving the glomerulus. It reduces the pressure to reduce the albuminuria. And what will happen is you're going to get some decline in renal function. So just remember, if it's more than 25%, think that they may have a renal artery stenosis. Those are the patients you could send to a nephrologist to check. But if it's less than 25% from baseline, just hang in there. Often it will sort of get back to where it is. Now, this slide we love because it just shows you. I just want to show you here with Rita. She's 160/95. If you can get it to 140, at 160/95, her decline will be 10 mils per minute. I told you on average, person declines 1 mil per minute. You can imagine how steep her decline is. If you can get it to 140/90, you get to about 6 mils per minute. If you can get to the target, 130/85, you almost at only a 1% drop. So you can change Rita's decline from, this is 5, so you can imagine 12 is like that at 160/95. If you can get a blood pressure controlled, you can change the decline. Now, you often need to have anti-lipid agents for these patients to reduce the cardiovascular risk. You've got to tackle glycemic control aggressively, and I'll go through some of those things. I always just talk about the SHARP study because it's very interesting. The SHARP study just put patients on a simvastatin combination with ezetimibe, and they had a 17% reduction in cardiovascular risk. And that was not even checking the cholesterol again. So you're just putting them on those anti-lipid agents if you're the highest risk. Just remember self-management, and I won't go through this because it's in the book. Lifestyle, very, very important still. And these are the aspects that you can really tackle in the primary care. This is just to remind you, and I'm putting this up again, because I often tell patients, if you're unwell, stop your ACE inhibitor for a week. If you unwell and you've got diarrhea or vomiting or you've got flu and you're still on your ACE inhibitor, you're going to get hypotension. And you're going to land up, there's a lot of these drugs are long-term, they're there for the long term. They're the long-term investment in reducing cardiovascular. Short-term for a week is going to make no difference. So just remember to stop these. A little bit looking at this algorithm here for diabetes. So usually early on, physical, nutrition, weight loss, up until eGFR about less than 30, metformin and SGLT2 inhibitors, so empagliflozin and metformin together, up until a GFR about 30. When you start going below 30, you've got to start looking at the GLP receptor agonists. So liraglutide, and often you've got to go back to the basics, insulin and the sulfonylureas. So you've got to stop the metformin and stop the SGLT2 inhibitors in these patients. So this is just a slide showing you that when you've got diabetes, you do have to look at changing the drugs. This was taken from the Ckd guidelines on managing diabetes with kidney disease. This is just showing you that your targets may also change. If you are CKD stage 1, you can go for much lower HbA1cs. If you are worse and the kidney is not working, you're probably going to have more albumin. You probably don't have to target as much because you can cause hypoglycemia. There's increased hypoglycemic awareness, and so you've got to target things slightly differently as the renal function declines. So should Rita come to a nephrologist? And, well, there are good reasons to send patients to a nephrologist. There is reduced rates of progression, there's reduced morbidity and mortality, hospitalization, and they're often more prepared for dialysis. There's also increased likelihood that they get kidney transplant. But equally so, if the eGFR fits into those criteria, you may want to refer the patients, because certainly in the book it says the proteinuria, you've got macroalbuminuria or GFR in stage 3 or stage 4, you definitely want to consider referring these patients, or if you can't control them, on a few agents. So those are clear indications to refer. When the GFR is more than 30 or the albumin is in the microalbuminuria range, and I'm going to show you even in the macroalbuminuria range, if the GFR is not so bad and you can control it, you can individualize care. So if you are going to refer patients, remember to come back to the kidney health check. Remember medical imaging, look at the medications. Make sure you don't have them on the triple whammy, non-steroidals, diuretics, and ACE inhibitors. Stop those. Even if you're on double whammy, stop one of them or both of them and see how the patient goes. And then if they do, obviously refer them. Now, Martina, Gleason is involved in health pathways, and this is just to tell you, and there is a link here. You can go to the health pathways, SEF Health Pathways website. If you register, you will see we've written these together with Martina. What are the criteria for? They are slightly different, and I'll take you through some of those. It very clearly tells you what are the reasons to refer somebody who's got non-acute kidney injury. And many of them I'm going to outline now. So I really encourage you to look at health pathways. All of us in the hospital are working with Martina and health pathways to write them so that you can go and have a look and see what are the criteria to send to St. George and to some of the nephrologists. So what we also use, and I think that in the next few years, this kidney health risk equation, the KFRE equation, you've often seen me refer it to you if you've referred. We use it to calculate the risk, and I'll just show you why. Here you've got a person who is 76, they got macroalbuminuria, and their 2-year risk of getting onto needing dialysis is 6%, their 5-year risk is 22%. Just if you have a look, if the urine ACR is microalbuminuria range, even with the eGFR in stage 4, their 5-year risk of needing dialysis is only 10%. That's pretty low. So one of the problems with our peak KHA guidelines is we probably over-predict those people who should risk. This is not yet in the guidelines, but this is something that we use at St. George. And the reason we like KFR is because there's a lot of research on it. We have validated it in our population group here at St. George. It gives you a 2- and 5-year probability of getting kidney failure. It is an association. It's not just a single EGFR or ACR. It takes the two and predicts them and shows the biological association of age, ACR, and EGFR. It helps us decide we can prognosticate. It also, Kylie and I use it with planning vascular access, who's going to come to renal supportive care. And the reason why it helps us is GFR is not always a linear straight decline. You can have a slow decline and then a sudden decline at the end. So one of the problems with KFRE score is it's only at the time that you do it. There are other scores that you can do, and these other scores are a little bit more complicated. In that same 70-year-old, you can get these scores that will tell you what's their chance of death only, death with cardiovascular disease. But the reason we like this Tangri is it's simple, and this is just showing you here with Rita. So I said that the question is, does KFRE change over time? Definitely. You're doing it regularly, but it does help you make decisions. So if you look at Rita, Rita's got microalbuminuria. Her EGFR is 52. Her 5-year risk of needing dialysis is 0.78%. Does she really need to come to a nephrologist at a risk of 0.78%? Just to give you a context, somebody who's about to start dialysis in a year has a 2-year risk on average around 40%. A 2-year risk between 20 to 40% is somebody we consider referring to our renal. So we follow this triage system in our clinic, and it's on health pathways. If you fit into any one of these categories, we review you early. But if your KFRE risk is less than 3%, we refer you back with a low-risk letter. Sometimes we see you in the clinic and refer you back straight away once we tell the patients. Some nephrologists will differ. If the risk is more than 3% at 5 years, then we will make a plan. And so you may get these letters from us. Hopefully I will not need to give these letters anymore after this talk, asking you for renal imaging or urine ACR, and just being able to, we need this information for triage. Sometimes we will refer a patient back, and Kylie sometimes will also do this when we've got patients tracking on our virtual consultation, and we refer you back and just tell you what to do in triage. And the reason that we do that is there's a study showing that you can really impact on referrals to a tertiary service if you use the KFRE score and without any risk to a patient. So just to finish off, just remember this conceptual model. Remember, there's all these targets that we aim for. Hopefully, you know why we're aiming for these targets: weight, obesity, stopping smoking, lipids for cardiovascular risk. We've got lots of drugs at hand to be able to target these things and change them, so they are available to all of us. This is just taking a study which I love from the same guy, Raganensi, who showed the association between ACR. This is from 2001. And you can see, he just said target these 4 things with CKD, and they're still there today in 2021. He targeted 125/75, which would fit in with some of the studies, but pretty much there are only a few markers that you can remember on your hand to target for these patients. So blood pressure, albuminuria, looking at lipids, and targeting blood glucose early on lower levels when the GFR is good. So what difference does CKD diagnosis make if you already manage these patients well? CKD is common, early detection is beneficial. If you know the risk factors for CKD, you can influence cardiovascular outcome. Remember to perform that kidney health check, maintain blood pressure targets consistently. I've shown you if you can move patients just slightly down, you can change the slope of their GFR decline. Look at that CKD staging and the clinical actions that will help you and give you a guideline. And most people with CKD can be managed in general practice. And hopefully you can finish today and do that. We just try and encourage you in Kidney Health Australia and Peak to sort of, what can you do in your practice? Know who's got kidney disease. You can look in, you can use the handbook and you can look at those risk factors. You can implement sort of recall systems. You can get those sidebars that you can do that can pick up CKD in your practice. And you can do your own screening for these patients. And I think you can often even enter into a care management plan with your nephrologist in these patients. So there are things to do. So that's pretty much the end. Just reminding you, you can go and get these downloads, or you can buy a hard copy if you want to from the shop for $15. There's lots of resources available for you on Kidney Health Australia guideline. I don't know if a lot of you have seen Think GP. We have got a few kidney talks that we give. This is Shilpa Jugelson, who's got one. And then just to tell you, there's a lot of people who support the PEAK program. So thanks for participating. Just remember, you can download it, but I also want to remind you, I should have had number 4, and I'm sorry, Martina, here saying, look at health pathways. Health pathways will help you also make that decision. So I've got a couple of questions that I've got for the next 5 minutes. If there are any questions, I'll try and get to the chat.
Stop sharing. Maybe stop sharing.
That's okay. That's all right. We can. So there was a question, does KFRE risk change over time? So it does. I told you it's individual. It will change. If the proteinuria worsens, KFRE will change. If you go into that website, it's a really nice website for the patient because it allows you to actually calculate the KFRE. You can actually give the patient a printout of where they fit on the KFRE score, and it just helps patients visualize their CKD. And it just also helps you visualize their risk. I'll just look at some of the other questions.
How often should they reassess KFRE?
So look, I reassess KFRE every time. If you're doing a kidney health check, you pretty much, every time you do a kidney health check, you've got a GFR, you've got a urine ACR, you can do just the one thing in the kidney health check. You can add more variables, calcium phosphate, which does slightly improve the predictability, but not by that much. So if you do go to the website and use it, it gives you the option to skip adding in these extra calcium and phosphate. I skip it and just go straight and just use the 4 variables. So there's a 4 variable score and an 8 variable score, but I pretty much just use the 4 variable score. It's as good. So I don't know, is there any other questions, Kylie, that I may have missed? Are there any questions somebody wants to ask? I have spoken to you about health pathways. Honestly, I've written the health pathways with Martina, so you can actually see, we talk about the kidney health risk score on there. I don't want you not to use, if you do still want to refer patients who fit into the red guideline, that's okay. We do understand if you've got any macroalbuminuria, you may want to get seen by a nephrologist. But if you are confident, you can go and use the KFRE score to use that. I think that's, yes.
Where does renal imaging fit in?
So Wayne has asked me, where does renal imaging fit? So I think if you've got anyone with hematuria, you've got to do imaging, because I said you've got to exclude a surgical cause. So is there stones? Is there some anatomical abnormality? Is there a malignancy there? So generally, if you're young, I do an ultrasound, but if you're over 50, I tend to do CT KUBs. I think if you are thinking of referring a patient, it means you're worried. So I think if you are referring a patient, you probably should do imaging. Just for reassurance, often I know that patients get anxious when they have little cysts, and I have sometimes referrals just for a cyst. You must remember that you lose some of your glomeruli over time. So everybody with CKD, or at least most people, will have some small cysts in the kidney. If you've got 1 or 2 cysts in each kidney and you don't meet the criteria for adult polycystic kidney disease, it's probably, if the cyst is simple and the radiologist has said it's a simple cyst and hasn't commented that the cyst is, they classify them by the Bosniak classification, they'll usually tell you if the cyst is worrying. If it's a simple cyst, it's probably just a few nephrons that have scarred up, and now all of a sudden they're filled up with a little bit of fluid from the tubules, and you get these tiny little cysts. So everyone will get them with age and with some CKD, but I would definitely do imaging when you're going to refer, and you should tell me what drugs the patient's on when you're making that referral as well. Any other questions out there? We've got another minute. Thank you for organizing this. Just to tell you that Martina and Taryn and Wayne have been involved on the integrated care group, of which we're on. And the integrated care group is looking to connect St. George and GPs, the hospital and GPs, and that's where this initiative of the education has come from. And over the next few months, we've got the program, hopefully, that will tackle a lot of departments that you refer to, and we'll try and cover the things that we've covered today. So thanks to all of you who are involved in that integrated care group and all the CNCs, if any are on today. We do appreciate that. And there's also a high care risk that we're going to be starting. We'll tell you a little bit about that over time. So I think that's pretty much at the end, Bertha. I just encourage you, please, to just fill in the assessments. Thank you very much for listening.